Hello, my name is Emily Hafemann, and I am a senior nursing student at Concordia University, Wisconsin. This semester, I was given the incredible opportunity to work one on one with Nancy Pinsack as my preceptor in the CICU to satisfy the requirements for my last clinical placement. Our final capstone assignment is to develop a quality improvement project. For us at CUW, quality improvement is based on a site specific project designed to propose a change in patient care or in the care delivery environment based on the evaluation of evidence based practice. After having various conversations with members of the interprofessional healthcare team, including nurses, doctors, NPs, OTs, and PTs, a topic that continued to come up was that of the lack of mobility on the unit. Here's an agenda of the information that I will be covering throughout the presentation today, including a literature review, a recommendation for change, and the financial implications of imposing that change. The purpose and goal of this project is to identify the issues contributing to limited mobility in the CICU, educate on the benefits of implementing an early mobility program, and determine appropriate policies to help increase patient mobility, improve patient outcomes, and ultimately save money for the unit. There is endless research available that describes just how important it is to keep patients up and moving while they're in the hospital. A common saying is, if you don't use it, you lose it, which is very applicable regarding mobility. The statistics shown here highlight some of the drastic consequences of immobility that occur following a hospitalization. Some of the ones that stick out to me include that the fact that hospitalized older adults with low physical mobility are 34 times more likely to die than those who ambulate 2 or more times per day. Also, up to 65% of older adults who are independent in their ability to walk lose that ability during a hospital stay. Furthermore, adults generally take about 15% of the steps that they would normally take at home while they are in the hospital. The effects of immobility can occur very quickly, as weakness in the legs and dizziness can develop within 48 hours of hospitalization, both of which impact patients' ability to move. Immobility also is expensive, as more than $26 billion per year is spent on additional medical and long-term care support for these patients. This background information and these important statistics highlight just how significant mobility is for our hospitalized population. Let's be honest here. Nurses in the CICU have a lot of things to be worrying about aside from getting their critically ill patients up and moving. As a result, there are not many nursing specific guidelines being followed in the CICU regarding mobility. PT and OT play a large role in determining a patient's appropriateness for mobility, and they do so by following their own specific protocols. The nursing staff then follows the instructions given by PT and OT. Unit-wide, a major protocol that is utilizing the gait belt for all patient transfers, as well as any other appropriate assistive device. The nursing staff is also to complete the CMET once per shift and following any acute condition change. As a hospital, St. Luke's has a safe patient handling and mobility with minimal manual lifting protocol that emphasizes the guidelines regarding early and progressive mobilization. Within this protocol are a variety of tools that can be used to assist with mobility, but the bigger issue is making it happen while our patients are here. There also currently is a team working diligently to decrease the prevalence of falls in the unit, which goes hand in hand with mobility. These next couple of slides highlight a couple of resources that are utilized by St. Luke's currently. You may recognize some of them, or you may have never seen them at all. I talked to several OT and PT workers in my time on the unit, and they have guided me in the direction of these resources, as they are more frequently used by these specialties. This document is a patient lift assessment tool, and it utilizes a flowchart to determine the necessary assistive device that a patient may need. This document also provides recommendations for equipment and activity based on mobility levels. This document is an early mobility readiness flowchart, and it utilizes a flowchart to determine if a patient is an eligible candidate for early mobility, which is very important in the project I am presenting. This chart is a patient mobility chart that discusses 5 levels of mobility and the activities needed to accomplish before advancing to the next stage. The chart on the right here is a sheet that is supposed to be utilized on every patient's door and updated as the patient's condition changes. It provides specific information about which assistive devices they may need. This right here is the CMET, or the Comprehensive Mobility Evaluation Tool. It's one guideline that is being stressed much more frequently, and it's supposed to be filled out by the RN once per shift, as well as with any condition change. It is used to help the team member assess the patient's ability to safely get out of bed and perform progressive mobility. As a new nurse, There is a learning connection module that walks you through exactly how to utilize it, but after hearing feedback from other veteran nurses on the floor, this education was not provided to them, and they had a difficult time understanding and adapting to this new policy. The best practice guidelines regarding mobility have been a recent focus of research. While it is very apparent that implementing early mobility protocols show promise, there's not one specific hospital-based program that trumps all the others. Furthermore, the best practice methods to measure mobility also remain unknown, which is why a variety of different tools exist, such as the ICU Mobility Scale, the IMS, or the CMAP. St. Luke's has their own early progressive and mobility protocol that is approved, as we discussed earlier, and this emphasizes the guidelines regarding early and progressive mobilization. Since St. Luke's already has one in place, I have focused this project on ways to improve the implementation of this already approved protocol. Before coming up with the recommendation, I did a lot of research. My lit review was guided by some defining terms, one of those being the ABCDEF bundle. This is a bundle where the A stands for assess, prevent, and manage pain, B for spontaneous awakening and spontaneous breathing trials, C for choice of analgesic and sedation, D for assessing, preventing, and managing delirium, E for early mobility and exercise, and F for family engagement and empowerment. And this tool promotes the assessment, prevention, and integrated management of pain, agitation, and delirium, while also facilitating weaning from mechanical ventilation and maximizing early mobility and family engagement and empowerment. Applying this in daily ICU practice improves patient-centered outcomes and promotes interprofessional teamwork and collaboration. Mobility is the progressive and active maintenance of or increase in physical activity of the healthcare recipient with or without assistance of healthcare worker action and safe patient handling and mobility technology. Going a little bit further, early mobility involves mobilizing, whether it be sitting or ambulating, during the first 24 hours of hospitalization, with progressive mobilization each subsequent day, increasing the frequency, duration, and intensity of this activity. This mobility program sets parameters on the initiation of early mobility, the duration according to how stable the patient is, and the proposed outcomes. It requires an interdisciplinary model to ensure and optimize safety, timing, and duration. The physician is responsible for making medical decisions. The respiratory, physical, and occupational therapists evaluate the patient's progress and assist in implementing the intervention. And the registered nurse helps implement the intervention, but also discusses the current medical status and proposed plan of care with the physician and therapist. This early mobility process is initiated as soon as the patient is medically stable. Here are just a couple of consequences that result from immobility in the hospital setting. Many patients develop neuromuscular dysfunction, and many survivors leave the hospital with physical, cognitive, and psychological impairments that prevent their return to full independence, and this is known as post-intensive care syndrome. Also, muscle strength declines rapidly with each additional day of bed rest. Once this dysfunction occurs, it can take weeks or even months to alleviate its effects. Prolonged immobility and bed rest are associated with physical weakness, functional decline, higher mortality rates, and an increased duration of mechanical ventilation. ICU-acquired muscle weakness can be present in 25 to 50% of critically ill patients and is associated with impairments in patients' long-term survival, physical functioning, and quality of life. Contrary to that, there are a variety of benefits to implementing early mobility. Providing patients the opportunity to be awake and mobile out of bed early and often during their ICU stay is the most effective treatment strategy for preserving skeletal muscle. It results in a shorter duration of delirium, reduced postoperative complications, and a reduced hospital and ICU length of stay. It reduces the number of days on mechanical ventilation, lessens sedation levels, and lowers hospital costs. Early mobility improves long and short-term outcomes and is shown to be safe, attainable, and beneficial. It results in a greater ambulation distance for patients as well. Other clinical benefits to incorporating early mobility include enhanced cardiovascular function, increased functional mobility and strength, preservation of neuromuscular integrity, improved cognition, enhanced endothelial function, and normalized blood sugar levels. Research showed that there are specific ways to implement an early mobility program. In order to effectively implement this program and have long-term outcomes, activity must be introduced within 48 hours of a patient's admission to the ICU. ICU patient mobility interventions that are started 5 to 7 days into their stay do not provide the same improvements. Also, it is important to note that benefits increase linearly with exercise. Nothing restores the walking ability in patients like taking more steps. In the realm of exercise as medicine, more is more. There also should be a tool prepared to accurately measure the effects of early mobility. An 11-point ICU mobility scale is one tool that measures the highest level of mobility in an adult ICU patient. An early mobility program should also be implemented with a team-based approach, specifically including physical therapists. Major indicators for safety initiating early mobilization need to be met and include stability in cardiovascular, respiratory, and neurologic status. Vasoactive infusions or mechanical ventilation are not barriers to initiating rehab and mobilization. Major indicators for stopping this include the development of new cardiovascular, respiratory, or neurologic instability, events such as a fall or medical device removal or malfunction, and patient distress. Electronic health record tools, such as specific flow sheets, reports, dashboard, and graphic displays, should also be used during early mobilization techniques. Implementing these can improve interdisciplinary communication and tracking of a patient. It can also increase the number of PT visits, improve mobility progression, and decrease hospital length of stay. This chart here shows several barriers that may be prohibiting the implementation of an early mobility program, but it also shows strategies that you can use to overcome them. I know there are a lot of words in this slide, so feel free to pause the video or come back later and take a look at them. There are four main types, being physical, structural, cultural, and process related. And a few that really stuck out to me in regards to barriers were patient refusal and lack of motivation, inadequate staff training, lack of mobility culture, and missing or delayed screening for eligibility. Most of these are things that we have the ability to control. So it's important that we take a look and figure out what is really preventing mobility from happening today. In summary, I use terms such as the ABCDEF bundle, mobility, and early mobility to research this topic. There are several life-changing consequences of immobility and benefits of early mobility. There are specific guidelines that should be followed when implementing an early mobility program, and there are barriers that contribute to the lack of mobility in the ICU, but also there are strategies that can be implemented in order to combat these barriers. Being in the CICU for 105 hours gave me significant time to gather observations and primary reports from nurses on the unit regarding their opinions about mobility. Nurses often describe feelings of uncertainty regarding how they should be mobilizing their patients, especially with how acutely ill they were. Mobility often gets prioritized very low on the list of things that nurses need to do. And that's very true because they need to make sure that their patient is hemodynamically stable and figure out what's causing their condition before they get them moving. PT and OT do not always see every single patient because they have a large workload themselves. Also contributing to the lack of mobility is that nurses are overwhelmed with the amount of charting that they need to do every single shift. And as a result, mobility itself is not always documented appropriately, but also the CMET was added, and that's supposed to be filled out every shift and with condition changes. And many nurses don't know how to do this. Like I said, there are training modules available, but we need to get these into the hands of our veteran nurses. Furthermore, the COVID-19 pandemic left several nurses feeling burned out. As a result, taking the extra time and effort to mobilize a patient is not always the main priority. Also, even though there are various protocols that St. Luke's has, they aren't always enforced and utilized. Mobility sheets also are not updated every shift. After gathering my own personal observations, listening to what other professionals had to say, and doing extensive research of my own, my recommendation for change is to initiate a dedicated ICU mobility team in the CICU. This would increase the number of patients mobilized, empower the nursing staff, and improve patient outcomes. It would meet the early mobility element, the E of the ABCDEF bundle. It would create a culture of mobility within the ICU, and it does not increase the overall cost of the unit and the hospital. This mobility team is based on a model that was implemented at Memorial Hospital at Gulfport, which resulted in numerous positive outcomes. Ultimately, this is a large change and it would require a significant amount of time, effort, and planning. A specific team would have to be assembled, an orientation would have to be done. There would have to be constant collaboration with the interprofessional healthcare team of physicians, nurses, nurse practitioners, and therapy staff, but that is all doable. After doing all my research, this dedicated ICU mobility team has had very positive outcomes and is the best way to improve mobility in the ICU setting. Like I said earlier, St. Luke's has a variety of resources and protocols in place, but in order to help implement them as they should be, this team could definitely help with that. As stated before, planning is a crucial component to implementing this project. This team will be focused, informed, and consist on staff members who will be placed in multi-skilled technician positions in order to allow for a broader scope for the position. The team members would be recruited from in-house and would include staff that were previously employed in transporter and various technician positions that required patient contact on many units, including the ICU, and had some limited assistance with patient mobility. They would go through a 4-week orientation period. It would begin with classes from professional development that would include training for documentation in the EHR, back safety and patient positioning in services, and training on safe management of catheters, use of patient lift devices, and safe patient handling. They would then shadow PT and OT and get used to the workflow and use of assistive devices. Then they would shadow the ICU nurses to become familiar with the safe practice and a wide variety of tubing, lines, and devices that are commonly found in the ICU setting. They would then receive an in-depth in-service on patient positioning by the wound care nursing staff. They would learn about proper positioning, offsetting bony prominences, changing positions side to side, avoiding shearing injuries, as well as proper techniques for floating extremities. Finally, they would receive orientation to the use of the bedside monitoring systems, ICU specialty beds, and safe handling of ventilated patients. The daily workflow would be unique for those on this specialized team. They would start with a chart review on each ICU patient, and they would work with the PT and OT for the day. Then they would also review a table that had specific exclusion criteria, as well as criteria that would terminate a mobility session, just to refresh themselves and know who can be included and when they need to stop. Then they would coordinate with the ICU nursing staff to establish a plan of care and a workflow for each individual patient. It would be their responsibility to complete and document the CMET. Also, they would assist patients throughout the day with functional mobility tasks such as toileting, meal assistance, sitting, standing, and ambulation. They would be responsible for turning all of the patients every 2 hours and keeping patients on that consistent turning schedule. They would perform passive range of motion on patients who are unable to get out of bed and participate in other exercises. They would assess the skin integrity of patients with every encounter, and if they were concerned, they would report it right away. It would also be up to them to properly update the laminated ICU mobility cards to indicate the patient's designated level of mobility for the oncoming shift. It was found that this is very important because when PT and OT staff members weren't present, if these cards were updated, the night shift nursing staff felt much more confident to mobilize their patients at the appropriate level. Finally, the mobility team members would be rotated between the different ICUs in St. Luke's on a 6-month basis so that they become flexible and familiar and comfortable with the multiple ICU settings and various ICU healthcare team members. Recent research shows that implementing a mobility team has a wide array of positive effects for the patients, for the staff, and for costs for the unit. I have previously discussed many of the positive patient outcomes, so I won't go into that again. Just know that the ones listed on this slide are specific to the research article that I based this program off of. In regards to staff, it was found that after implementing this ICU mobility team, there was increased nurse satisfaction. Their concerns related to patient safety and self-injury improved. They believe that this mobility team staffing should be expanded over the night shift and on the weekends. They believe that they had more time and were well supported with the mobilization of their patients. They felt turning was a priority, patients were out of bed as much as it was appropriate, and the implementation and training process were fairly simple. The nursing staff ultimately felt more supported and were more open to mobilizing their critically ill patients. This allows the culture of immobility to shift to viewing mobility as medicine with a more positive and enthusiastic response to PT and OT and participating in the continuum of patient care. In regards to cost, the financial implementation of this project resulted in positive outcomes related in specific to ICU staff injuries, but it also offsets the use of costly PT units. Despite an increase in research focused on early mobility, as stated before, there isn't one program that is the best yet. And there also is not one tool that best measures mobility. So it makes it difficult to kind of evaluate how effective some of these methods are. Also, there are a variety of resources and protocols available at St. Luke's that are not always enforced and implemented. I believe that these gaps can be bridged with the implementation of an ICU mobility team. This team will be able to address these protocols and topics that nurses do not always have the time to do, and often it gets overlooked. An emphasis will be placed on turning patients, active and passive range of motion, implementing the early mobility protocol, and updating the necessary mobility sheets in order to encourage mobilization throughout the various shifts. Through the research conducted in the LIT review, there are both consequences of immobility and benefits of increasing mobility. These results have a direct impact on the cost of care for a patient in the ICU. The cost of care in an ICU is already very high, so one of the main focuses of this ICU team is that it has the ability to decrease the average length of stay within the ICU. It also lessens the number of employee injuries and lessens the prevalence of pressure injuries, falls, and days on mechanical ventilation. To start, the average length of stay in the CSU is 3 to 5 days. Intensive care unit costs are highest during the first 2 days, and it progressively gets lower. By implementing a dedicated mobility team, this can reduce the length of a patient's stay and in turn substantially reduce the total inpatient cost. The same can be said of employee injuries. The average direct cost of one injury is $15,860. Implementing this team can prevent these injuries and in turn alleviate the cost. The CSU had 6 workplace injuries over the past year, but luckily none of them resulted in lost hours. When this was implemented at Memorial Hospital at Gulfport, they ended up saving about $35,000 a year because of the reduction in employee injuries. When a pressure injury occurs, one case costs an additional $44,180 for the unit. The specialized education provided during the orientation process, as well as placing an emphasis on a turning schedule, will help decrease the prevalence of pressure injuries in the CSU and reduce those costs. Finally, the average added cost per fall is $13,063.50. As I stated earlier, this is currently being evaluated by a specialized team of nurses, PTs, and OTs, and nurse practitioners, and adding an ICU mobility team can help further alleviate some of these falls through more accurate identification of patient status and their needs regarding mobility. The costs associated with patients on ventilators are much higher than those not ventilated. Mechanical ventilation results in a 59% average cost increase. By reducing the amount of days a patient is on a vent, the cost of care will also be reduced. As you can see by these numbers, comparing the cost for a patient who's vented and a patient who's not is insane. So it's really important that we utilize it for the least amount of days as they need and try to keep them off it if at all possible. As we all know, equipment is expensive. In the CSEU, every room is equipped with a walker, gate belt, ceiling lift, and chair alarm. Walkers, gate belts, and chair alarms account for less than $200 per room. The ceiling lift is about $4,000 per room. Adding this up, multiplying it by the 24-bed unit, comes out to a grand total of $100,800, which is a lot. The unit also owns a variety of other assistive devices that can be utilized by multiple patients. The motorized Sarasetti sit-to-stand costs about $5,000, and the non-motorized costs about $1,500. I found a study in the Intensive Care Medicine Experimental where they developed a financial impact model to simulate the impact of introducing an early mobility program in an ICU. They accounted for many variables, such as the annual number of ICU admissions, ventilation status, insurance type, improvements in clinical and administrative outcomes, such as length of stay, days on a ventilator, rate of readmission, costs associated with these outcomes, and startup and operating costs were also included. And it showed that approximately $929,000 is saved annually. Also, the impact of this program on hospital readmission saves hospitals about $93,000 annually. Overall, I believe that despite the significant amount of time and effort it will take to implement this team, the overall savings from the decreased length of stay, falls, stays on a ventilator, and employee injuries will outweigh the costs. In order to accurately determine the financial needs of this project specific to St. Luke's, further research and planning will need to be done. It will need to be looked into, such as the implementation costs with the orientation period, different in services, education modules, shadowing hours, training hours, the proper salary for this IC mobility team, as well as the role of the CNA on the unit while this team is there, in order to know just how much money it will save St. Luke's and the unit of the CICU in general. In conclusion, by implementing a dedicated ICU mobility team in the CICU, long-term outcomes would improve by increasing the number of patients mobilized, empowering nursing staff, and improving patient outcomes. This would also meet the early mobility element, the E of the ABCDEF bundle, and would create a culture of mobility within the ICU without increasing the overall cost of the unit and hospital. Obviously, implementing this team would not be a simple undertaking, and it would take a while to get the necessary personnel on board, as well as a significant amount of planning and effort in general. Based on the research I have done and the resources already available and utilized at St. Luke's, I believe that the final savings that result from decreased length of stay, decreased falls, decreased days on a ventilator, and decreased employee injuries will cover the initial implementation costs, and the benefits for our patient population will outweigh the potential risks. Once again, I would just like to thank the whole unit of the CSU, but specifically Nancy, Bill Edwards, and Ginger Weber for welcoming me with open arms. I learned so much throughout my time here, and I will take everything I've learned into my practice as a newly registered nurse. If anyone has any questions about this presentation, please feel free to reach out to me at the email below, and I would be happy to talk with you and answer your questions. Finally, here are the references and resources that I used throughout this project.